discuss a topic which is becoming more and more, a topic that, an issue that affects young women, and more and more women seem to be concerned about it, are searching for information on this, and grappling their way through it. Today we bring together a very interesting panel, and we talk about PCOS, obesity, and fertility. Quickly introduce the panelists. So for those of you who don't know, we are PatientsEngage. We are an online platform which seeks to inform, engage, empower patients and caregivers in order to manage their chronic conditions better and to live, to make better decisions and have a better quality of life as well. Our panelists today are, we have with us Anjali Kurian, who some of you know. She has been on our webinars in the past as well, both as a caregiver of a kidney patient, her own brother, Sunny, and therefore she started the Sunny Foundation, which supports kidney patients. She's also RJ at Radio Mango, and she has lived experience with PCOS, and she'll be talking about that as well. We have with us Dr. Usha Sriram, physician, endocrinology and diabetes specialist. She is a strong advocate for women's health and is founder of an organization called Diwas, which focuses on, again, women's health, chronic conditions, quality of life for women. Dr. Sheela Nambiar, who is OBGYN and a board certified lifestyle medicine physician and a fitness consultant. So that's a unique combination. And we think that it's, a combination that we will see more and more of, and we should probably see more and more of as we go forward. And for those of you who don't know me, I am Aparna Mittal. I'm the founder of PatientsEngage. Just a reminder to everybody, a few rules. This session is being recorded. If you're logged into Zoom, you can post your questions on the Q&A. If you are on Facebook, YouTube, or LinkedIn, you can post the questions on the live feed. And as always, you can write to us at editor@patientsengage.com. Again, a reminder that the information that is being discussed here does not replace a medical consultation. We are providing information, but specific medical issues it would be best to discuss with your own treating doctor. Or, if you want to reach out to our panelists, you can reach out to them separately. And on the topic of PCOS, next month, watch out for the fact that we will be talking specifically on PCOS and teen issues as well. Okay, we'll come to this. Just keep this picture in mind as we start the discussion, but we'll share the picture again. So good evening, everyone. Thank you for joining us today. Dr. Usha, let's start with you. What is PCOS and what are the typical symptoms that people should consider when they're, thinking of themselves as having PCOS?
First, thank you, Aparna, for doing this program. I think it's such a need of the hour, and thank you for asking me to be a part of this great panel. Thank you so much. So PCOS or polycystic ovary syndrome, simply put, is a hormonal disorder of women of reproductive age. And we define reproductive age as between 15 years and 49 years, or at least 15 to 45. Having said that, it has actually impact on women throughout their life. So that's the first thing to remember. It's the most common endocrine problem of women of reproductive age. So it's that common, probably somewhere around 10 to 15% of women in that of women of reproductive age. And in India alone, there are something like 330 million women between ages of 15 and 49. So that's a huge number. Right. As far as symptoms of PCOS, which you asked, so typically women can present with menstrual irregularities or no menstruation, what we call amenorrhea, or they present to us with clinic features of male hormone excess. Both men and women have male hormones normally, but women with PCOS have a little more of the male hormones, and therefore they may have more acne, oily skin, facial hair, body hair, hair that should not be there, and hair loss from the scalp. So typically men have balding and body hair. So the same thing kind of happens to women as well. They lose hair on their scalp and then grow hair on your face or chest or upper back or lower back. And and then the other symptom is they may have some difficulty with getting pregnant, and what we call subfertility or fertility issues. So these are the usual symptoms. And then anywhere from 50 to 60% or more of the women with PCOS are overweight. So that may be another symptom that makes them come and consult a physician.
Thank you, Dr. Usha. Anjali, let's start with you, right? Tell us what were your early symptoms and when did you get to a diagnosis, and how long ago are we talking?
Okay, so just to put things really straight for everybody so that you all don't realize, so you do realize that I'm a bit ancient. Being 49 today, I realize everything is so available for our trigger happy generations, whichever age you belong to. But way back when, I think about 28, 29 years ago, I was all of 54 kilos, absolutely fine. You could know the day of the month because that's when I got my period. Fast forward to getting involved and getting married and things like that. And I slowly but surely started on putting on weight, and I kept thinking, oh, it just must be the happiness of youth and love being in the air. But I didn't have any other symptoms. Nobody knew what PCOD was. You never spoke about your ovaries and your uterus and your periods to anyone. You just went back into a little hole and you were never allowed to say that you even had pain. Hot water bottles were given to you, if at all. You never spoke about these things. And then after getting married, I tried to conceive and it was just not happening. And then, of course, everyone's like, oh, you travel too much. It must be the stress, all of that. And finally, I did get pregnant with Aisha. And little later, again, obviously you want to have another child and stuff, and I just couldn't. So my brother was not well, and I went to see a doctor, and I was praying to myself, God, please let it be thyroid, because that's the only weight gain kind of disease that you know. And I'm like, God, please let it be thyroid. And the doctor looked at me and she said, Binu actually said to me, Anjali, I don't think you have thyroid, you have PCOD. And I'm like, what is PCOD? This is 20 years ago. She said, oh, it's an ovarian thing. And right now we don't have much. We don't have, of course, they didn't have that much of research done and enough knowledge, but she had, because she's an intensivist. She was very, very clued in on certain things. And she asked me to, why don't you start taking a little bit of metformin? Of course, the whole world went crazy. How can you take a pre-diabetic drug? You don't even have a problem. Your sugars are so low. How can you go to, first of all, a male doctor, but anyway, and then this other doctor. But my gynecologist was also quite privy to all this. And he said, yeah, Anjali, I think you should just try it. And sure enough, after starting to take it, I started losing some weight. And within 3 to 4 months of losing weight, I ended up conceiving Riyadh. And that was all fine. Both my pregnancies, I think because of PCOS and a hidden thyroid, I put on only 11 kilos. Perfect. For the rest of my life, I put on 62. So that's a totally different way to be. But after Riyadh, again, after 1 year, I started putting on weight, slowly but surely. From 105 kilos, I came down to 95. Then it became 105, 115, 125. I went to an obesity specialist, Dr. Johnny Kanampalli, who actually helped me. He's a dietologist and an endocrinologist. And he put me on the weighing scale, and the weighing scale just stopped at 120 kilos. And I was like, okay, now he said, we'll take you to the other weighing scale. Luckily, that didn't stop. It moved and stopped at 129. And that's when I knew, oh God, this is what PCOD, PCOS is all about. Everyone thought it was very fashionable that I said it because there was not enough data there, without realizing that this disease, unfortunately or fortunately, doesn't really leave scars. So what doesn't bleed and what doesn't show is not a disease. but it usurps your whole body and your mind and your soul because you have no control. You don't know how it hit you. It's not because you ate wrong. I used to exercise. I was more flexible when I was fat than I'm now. And it was a very lonely place to be. Yeah. But today I'm really happy to be here, Aparna, and with Dr. Usha and Dr. Sheela, who's not only a doctor, but a very close friend of mine. I've known her all my adult life, and I'm so happy to be with all of you here. I'm so happy actually that we are talking about this, that there's conversation about it. I want all of you to remember, though I know it's a little maybe off, but if I didn't bleed, you wouldn't be there. So let's talk about this and let's talk about it openly. It's about time, really. Yeah.
Thanks. Thank you, Anjali. Before I come to you, Dr. Sheela, Dr. Usha, can you just clarify, because I think this gets talked of whether it's PCOS, whether it's PCOD. If you can just clarify that.
Short answer, PCOS.
Right.
Because polycystic ovary syndrome, and syndrome just means a constellation of different things, and which is really what PCOS is. There's this and this and this and this, and it's a constellation. It's not one thing. Whereas the other reason why we kind of shy away from PCOD is D stands for either a disease or disorder, and as this PCOS comes with a ton of stigma and taboo, and we didn't want to add another layer of that to describing the condition. So as much as possible, I mean, we try to stick to PCOS.
Right. Okay. So Dr. Sheela, clearly in the case of Anjali, and this is obviously many years ago, the diagnosis of PCOS was not as common. It was not, I think it wasn't as obvious. Are you seeing more, kind of earlier diagnosis of PCOS? And who was the first point of contact for most young women or even teenagers?
First, let me thank you, Aparna, for inviting me here. I'm really happy to be here. As Dr. Usha and Anjali said, I think these conversations definitely need to happen. They seem to be happening a lot on social media, but they need to happen more because patients need to be more empowered to understand what's going on. So to answer your question, yes, we're seeing a lot more. When I started practice way back in like Anjali said, you get to kind of revisit how old you are. But when I started in 94, you did not see this many patients who were being diagnosed, so to speak, with PCOS. Nowadays, you do see a lot. One in literally every 5 to 6 patients comes with the ultrasound report of polycystic ovaries. Now, are they being diagnosed earlier? Well, I think the word diagnosis itself is kind of sketchy because there are criteria which have to be fulfilled for you to actually be considered PCOS. But a lot of the time, just an ultrasound diagnosis of multiple cysts in the ovaries, the diagnosis of PCOS is made. And that's not necessarily true. So yes, you may have polycystic ovaries, especially in and around menarche, that is when you start your period. Periods can be very irregular. They can come once in, say, 2-3 months. They can be prolonged. And there will be some cysts in your ovaries because this hypothalamo-pituitary ovarian axis is not really mature as yet by then, at that point. So you could have erratic periods. A lot of young teenagers do have that. So it's not necessarily polycystic ovarian syndrome. However, if the young child is overweight, especially with a larger abdominal circumference, and if her lipids are done and her lipids are on the slightly higher side, all of that, then yeah, you do need to consider it as PCOS. But you shouldn't, straight away label her as PCOS when you just have an ultrasound diagnosis of multiple cysts.
Okay, thanks. And coming back to the question, who are typically, what is
Yeah.
the experience? Are people going first to a gynecologist, or are they going first to a dermatologist because of the dermatological symptoms?
Yeah. So
Or
I
are
think,
they going to an endocrinologist because of weight issues?
yeah, I think that depends entirely on which symptom is really important to them, right? Because if it is the period, then they come to the gynecologist. If it is infertility or subfertility, they come to the gynecologist. But if it is things like, darkening of the skin and hair growth and balding and all of that, then they most likely go to an endocrinologist. Now, where I practice a lot of primary healthcare because it's primarily rural. So all these problems come to a gynecologist. We don't necessarily have an endocrinologist. So we need to refer to an endocrinologist where required. But I think in the cities where there are more endocrinologists, it depends on the symptoms and depends on what's most important for the patient, and not just the patient, the family.
Right, right. Dr. Usha, anything that you'd like to add to that?
Yeah, I think exactly what has been said, and sometimes weight issues. They may go to their physician or
Right.
come to an endocrinologist for that, and a lot of dermatologists also see young women with acne and what we call hirsutism or hair growth over their body. So it just all depends. Very much like Sheela said, what is the predominant symptom for that patient, and also, who is well known in that area for PCOS. Sometimes people Google and find out and go.
Right. So talking of Googling, are you also seeing a lot of self-diagnosis, Dr. Usha? And is that good? Is that bad? What's the risk associated?
There's a lot of self-diagnosis because a lot of patients walk in and say that I've come to see you because I have PCOS, or they say they have PCOS, and they've made the diagnosis. And um, some of them are, they probably landed on the right thing because it's, pretty much connecting the dots. You have irregular periods and you have some of these hair growth, acne type of things, and you're overweight. Chances are you have PCOS. Chances are. But I'm saying that the problem with the self-diagnosis is also either it can be over-diagnosis, because as Sheela said, a lot of young, especially adolescents, have polycystic ovaries on ultrasound. And 25% or so of normal girls, normal women, have polycystic ovaries on ultrasound. Overweight or obese is a common problem. Menstrual irregularities can happen for other reasons. So it's really important for the physician to go through the history, do a complete exam, do the appropriate tests, and come to the right diagnosis. And the other thing is not just overdiagnosis. You can end up with misdiagnosis, meaning patient is actually having something else. And so PCOS is also, I just want to emphasize here, is a diagnosis of exclusion. There are some really important conditions that have to be ruled out, like Cushing's syndrome or congenital adrenal hyperplasia or prolactin problems or thyroid issues. These all have to be ruled out before calling it as polycystic ovary syndrome. So yes, so self-diagnosis is not a good idea really for anything, and especially a condition that is probably going to impact on women throughout their lives, and they need guidance from a professional.
Right. And, you talked of the ultrasound not being, both of you talked of ultrasound not being definitive. Is there anything that is kind of a minimum requirement to, as a diagnostic test? Or no, it's just, as you said, exclusion and, clinical.
So the most recent and the most approved and accepted diagnostic criteria what we call the ESHRE criteria or Rotterdam, says that you need to have 2 out of 3. This is for not for the teenagers you're going to talk about next month, but for the adults, 2 out of 3. Number 1 is irregular menstruation, or what we call anovulation. Number 2 is features of male hormone excess, either clinically or by blood test. And third is polycystic ovary on ultrasound.
Right.
You have 2 out of 3 to call someone as PCOS.
Right. Right. Anjali, you were smiling at that point. Do you have anything to add there?
So the thing is that why most people Google and self, say that I have got PCOD or PCOS or thyroid, is because many of them are not ready to try and change their lifestyle and stuff like that. So they'll see me do something. And of course, they'll say, hey, why are you doing this? And I'm like, I've got thyroid and I've got PCOS. And even I must be having it. Can you give me your diet? Okay. And I'm like, no, I can't, because okay, I will, because I've always shared everything. I said, but you can't that. No, I'm also getting this and I also have that and I have the other. And that's when I say to them is that if you have to walk this talk, then you really have to talk the walk as well. Then you have to go and do all the tests and everything. The second reason why I was smiling is because you're talking about the test that says 2 out of 3. I never had excess hair and I never had irregular periods. So it was very difficult that why I became like that. And then somewhere down the line, my thyroid levels were not too bad, but my doctor had asked me to do an anti-TPO. My gynecologist asked me to do an anti-TPO of thyroid, and that came to over 1,000 something. And that's why I was having really very heavy periods full of clots and etc. So maybe the reason I look like Dr. Spock without much eyebrows is because the thyroid took off the hair. But I'm happy for it because at least PCOS didn't get me that way. So a lot of people actually just Google it because they think that there are shortcuts to it. I know people who've taken metformin and Thyronorm even without being a patient. I know people whose trainers have given them these medicines so that they could enhance weight loss. And I said, you don't need to do this. I said, it's so easy. You've taken the medicine and you've lost weight. Yes, but do you know what it does to your hair? Do you know what it does to your digestive system? Do you know what it does to your bones? So to make sure all that doesn't happen, you lift weights, you eat right, you exercise. Even if you breathe, you put on weight in this disease. So, it's, I just find it really unfair because now it's all there and everyone's sitting at home and say, oh, I have PCOS. No, you don't. You really need to spend some time and money to get the right experts to tell you exactly what's going on with you. Because I think PCOS changes, and correct me if I'm wrong, I'm with 2 really amazing women who know everything about it. But I think every stage of your life or every decade of your life, PCOS manifests itself differently. It's not just the way it was for me. PCOS when I was 30, PCOS when I was 40, and PCOS now at the brink of 50 and nearly fully menopause is totally different. It's it's like the 3 bears and Goldilocks, except it's the same bear growing up. So all different things happen, So yeah, that's why I was smiling.
Okay. Oh, I like that. I'm going to use that, Anjali.
Thank you.
Dr. Sheela, Anjali's brought up the point about lifestyle management, and you've kind of now, you are a qualified and certified lifestyle physician. And anything goes these days under lifestyle, right? So what does lifestyle management really mean? And, what's your advice to people specifically around PCOS, but in general on, lifestyle management?
Yeah. So when we talk about lifestyle medicine, yes, you're right. Anything, this term lifestyle is just very, very popular nowadays, and it's, everybody's using it quite freely. In lifestyle medicine, what we do is we use evidence-based protocols, advice for patients for chronic diseases like this, like PCOS, like diabetes, hypertension, etc. But whatever is prescribed and advised has to be evidence-based. So it's not just, some superfood that is, will help you lose weight, or this particular diet that will help you drop 10 kilos in 10 days. It has to be evidence-based, preferably randomized controlled trials and so on. So when you talk about lifestyle, we normally address 6 pillars of lifestyle, which is food, nutrition, exercise, sleep, stress, social connectedness, and addictions. So these are the 6 main pillars. And every one of these pillars have a role to play in most of the chronic diseases. So one may play a more important role for some people, like diet may be the thing that's really off the charts for somebody. For somebody else, it may be exercise. For somebody else, it may be stress, and then all the spin-offs of stress. Sleep has been found to be extremely important, even for women with PCOS who have problems with sleeping, etc. So all of this needs to be addressed. It's not a one particular rule alone. It has to be quite extensive. So what we call as motivational interviewing that we do, it explores every aspect of the woman's life. Sometimes going back to childhood, sometimes going back to trauma, sometimes going back to, you really need to explore it, and then come to an understanding of, for instance, we do know that weight gain is associated with PCOS. So which comes first, the PCOS or the weight, right? So either way, the weight has to be addressed. And then you have to think about why the weight is, there in the first place. No doubt PCOS prevents, or rather, women with PCOS find it far harder to lose the weight. They have very poor exercise tolerance, for instance. They get tired quite easily and all of that. But still, we need to address other aspects, because it's not just the food alone. It could be stress eating. It could be something, that comes back from her past. So a lot of history taking and counseling and talking and hand holding, for the patient. It doesn't happen overnight. It doesn't happen with one consult. So anyway, to bring it all together, it has to be a multi-pronged approach. And there has to be what is called a therapeutic alliance with patient and doctor. It's not just a prescription that you write and slip across the table. It has to be, because it's not a disease it's not a problem that is solved overnight. It's a long-term thing.
Right. And Dr. Usha, Anjali talked of, PCOS being different at different stages of life. Can you kind of talk us through that a little bit, and how does that affect women?
So we are aware of this irregular periods, which means it has to be post-puberty, right? Just to bring up two things. Babies who are born low birth weight, meaning small for gestational age, they are also possibly at high risk for PCOS is one. And girls who have early signs of puberty, premature, adrenarche, premature axillary hair, pubic hair, that kind of early features of puberty can also be one feature. But then really what happens, next comes this adolescent girl with PCOS, then comes the young woman with PCOS, and then comes the difficulty with the pregnancy. Then comes pregnancy losses are increased in women with PCOS. And if they do succeed, they make it gestational diabetes. They are also at increased risk for high blood pressure during pregnancy, gestational high blood pressure. And if they give birth to a baby, because when you have high blood pressure and things like that, you can have a low birth weight baby, and the cycle repeats itself, right? And then as they go into adulthood, again, all these things about excess facial hair, and to add to what Sheela was saying, a lot of women with PCOS have eating disorders. Bulimia and binge eating, night eating, they may have those issues. They also have a lot of mental health issues, anxiety and depression, and body shaming, body image issues. So those things can predominate as they get a little older. Then when they get to menopause, as Anjali was saying, the menopause by itself causes body composition changes and weight goes up, and people can have what we call metabolic changes. And that's one important aspect of PCOS that as an endocrinologist, I'm most worried about, that they are at risk for diabetes and heart disease. So all of that starts, to pick up pace around that time, because as they have problems, and as they get older, heart disease. So and then certain cancers, especially cancer of the uterus, because of the see, women can happy when they don't get menstrual cycles for months on at a time, but that's really, they should not be thinking of it that way, because it increases their risk for cancer of the uterus. So PCOS has got an effect on a woman's life throughout her lifespan, from birth till old age.
Right. That's, yeah, that really makes it much more complex than most people think of it, right? So, and you said that it affects pregnancy, and then that there's a risk of gestational diabetes. But one issue that keeps coming up is how it affects, kind of conception itself, right? Or fertility and getting pregnant. Do you, Dr. Sheela and Dr. Usha, want to talk about that a bit, to explain to people in simple terms why that happens, and then maybe you can start, Dr. Usha, and then Dr. Sheela, you can tell how people can manage that.
So I'll defer it to Sheela, but very quickly, just that the main thing is that an ovulation, or they're not making the eggs.
Right.
That's the basic problem. So we need an egg to get pregnant. So that's the biggest issue, with women with PCOS, and some other issues like prolactin, and then short luteal cycles and stuff. And Sheela, if can talk about that probably.
Yeah. Yeah, the main problem is, of course, like Dr. Usha said, it is anovulation, right? So that is the reason why the periods get so delayed. And the amount of the hormones that are produced as well, it's a hyperandrogenic environment, which means that their male hormones are elevated. So even when they do conceive, let's say with some help, the chances of early pregnancy loss, early abortions, or if they carry their pregnancy further, the chances of having a low birth weight baby, intrauterine growth restrictions. Then on the other hand, diabetes, gestational diabetes, high blood pressure during their pregnancy, going into PIH and eclampsia or fits. All of these chances of all of these happening is much more for a patient who has PCOS. So her pregnancy itself, while it's difficult to begin with, getting pregnant, the pregnancy itself is a more of a problematic pregnancy than for a woman who doesn't have PCOS, right? Because her hormones themselves are completely awry, and it's not really supporting the pregnancy the way it should, right? And in all probability, she's been through maybe infertility treatment, where she's already had a whole lot of other hormones to get her pregnant. So all these issues are there. So my advice is always, try, and especially if the woman is young, some of them come with, diagnosis of PCOS and they said they want to get pregnant. I always tell them to try and get their own body into some semblance of, you're not cured of it, but at least some semblance of health, where at least you learn what to eat, what to avoid, more importantly, how much to exercise, how to manage your stress, how much to sleep. Get a hang of that first before you try and conceive, because pregnancy, post-pregnancy itself is a stressor for the body. Right. So try and get into a healthy state before you get pregnant and before you start off all the treatment for infertility as such. And the amazing thing is, some of the time when they just start getting healthy, get their health in order, get their diet, get their exercise, they conceive spontaneously.
Right.
And that's the amazing thing. And then they're so thrilled about that. They don't need all the hormonal injections and things like that. It's very empowering, really.
Mm. And is there, I remember reading somewhere that a 5% weight loss itself kind of
Absolutely
increases
the chance of pregnancy. So I think for a woman, a lot of the time, I mean, as far as I'm concerned, I think empowering her to take care of herself is far more is far better than just treating her with medication. So she gets a hang of how to take care of herself. It enables her to take care of her child as well, because a lot of the time the food, the food habits of the mother, that's what is transferred to the child, because the mother is doing the cooking. A lot of the time a mother will bring her overweight adolescent or a young daughter and say, doctor, she has PCOS, but the mother herself is overweight and she's probably cooking really badly at home, and the entire family is eating badly. So targeting just the child is it's not going to solve the problem long term.
Right.
I think this is really not just an individual problem, it's a social problem and a cultural problem as well.
True. Yeah. No, I think, our food habits are a cultural problem, I think, in our country. And we also believe that we show our love through asking
Food.
people to eat more. So, so I think that's a factor as well. We are talking to Dr. Usha Sriram, Dr. Sheela Nambiar, and Anjali Kurian. And if you have any questions, please ask on the live feeds. Anjali, you, despite PCOS, etc., had 2 pregnancies. Did you have any issues during the pregnancy, or you did mention that you had difficulty conceiving, but once you conceived, did you have any challenges? Was there any advice you were given about managing the pregnancy better in terms of not getting gestational diabetes?
So actually, my first pregnancy was literally a song and a dance and a celebration, obviously, because it's the first child. The second pregnancy happened when I was closer to 31. And as soon as I got pregnant, I remember I started spotting. And then I had to lie down in bed for like 40 days with progesterone being put inside me and, stuff like that. So it had to be, you had to take rest so that it was okay, constant scans. But I must say, Dr. Jacob, who's 95 plus now, God bless him, he's amazing. He's still there. And he keeps telling me, the first thing he looks at me is, I'm so happy you're looking thin now. But he used to always tell me, he said, the minute you can get out of your bed, you have to walk. And he also told me, don't give your children all this rubbish that is there in packet food. Don't put all this baby oil and all of that. He says, put everything that you can get naturally. And the mistake I made with Aisha, because I was overwhelmed with the pregnancy, I didn't make with Riyadh. So I was making a lot more home food and making him taste food when he was about 6 months old and stuff like that. No, I didn't really. If I come to think of it, God's been kind. Other than that, I did not have any problems. In fact, I think my hormones were the best when I was pregnant, because I just put on 10 and 11 kilos while I had my babies, and they were good, healthy, big, long babies, as you would say. But also, since we are talking about this, I would like to say on this forum that there are a lot of women out there who are extremely thin and have problems with lots of acne and a lot of hirsutism. They have regular periods, but they also have PCOS, but they don't look at it because they're slim. Another thing is, like I was telling you about Goldilocks and the 3 bears, it's literally that, oh, this porridge is too hot for me, this porridge is too cold for me. And in today's generation, the children and the people who are between, say, 15 and 25 and 30, they are really exposed to a world where everyone talks about everything, It's a much more open world. But as Dr. Sheela was saying, and even Dr. Usha was saying, you really don't know. I mean, from the minute you are born a woman, I think there are a whole lot of problems. You're constantly going through stress, whether you're menopausing or you're PMSing or you've got your period or you're having your baby and then you have the baby, then postnatal depression. Then, it's constantly a bag of crazy things that keep happening to you because of your hormones. And I really wish that people would understand that it's not something that they have this thing, wo to pagal hai, wo to what the case hai. That means, oh, she's so mad. No, these problems are real. They exist in my head. They usurp my body. I don't have control of it sometimes. I'm trying every day to get up and be happy and motivate myself to go out there and do what I do. Because honestly, I believe in 10 years from now, if I do what I have to do, I will be in a better space. thank God I started doing what I did in my late 20s, because I wouldn't be standing here or sitting here having this conversation. And it's so it's sometimes scary because people don't understand what it is. People think it's just flippant because everybody in Vogue magazine and Cosmopolitan had the disease and how they got over it. But there are real life people who don't have access to funds, do not have access to doctors, and are fighting this debilitating disease or syndrome, which they don't know what has happened to them. There are people like me who didn't eat at all, and I was still 129 kilos. So Dr. Johnny Kanapalli said, Anjali, you have to have this. You have to eat 4 times a day because metabolism is so bad. And if I ate, I was eating, when I got up at 4 o'clock in the evening, I was eating a whole loaf of bread, or I was having a whole packet of biscuits. But if you ask me, what did you eat in the day? There was nothing else that I ate. So you have to really restructure the way you think and the way you want to think. And it's a tough journey, but I think today there is so much of help out there. There's so many more conversations happening. And just for the sake of your friend, don't be flippant. Try to understand what he or what she is going through, most importantly, because by just saying, oh, even I may be having PCOS, is just undermining it. It's not something that you read on the internet. It's very Instagrammable and it's extremely Twitterable and very good on Facebook, but it's not the way it feels when you're living the disease. There's a lot that goes into it.
Right. Um, thanks, Anjali. Um, Dr. Usha, can you talk about thin PCOS? I know that I think there is this confusion as well that happens. And since Anjali brought it up, I think it's worth clarifying that as well.
We call it lean PCOS and
Sorry?
lean.
Lean PCOS, okay.
So as I said at the beginning, anywhere from 50 to 60% of people are overweight or obese. So the rest of them are either normal weight or some even, thin. And the reason being that whatever is the basic underlying problem, whether it's insulin resistance or the other hormonal changes that they are undergoing, is that is not dependent on weight. What weight does is amplifies those problems. So
Right.
you have the lean PCOS person, all the insulin resistance, hormonal problems at baseline are there. And to this person, if you add weight, everything gets amplified. And this is one of the things I want to explain, that people may be, menstruating even regularly and, going along fine in life. And then they go to a hospital or they put on weight for other reasons, or like Anjali got happily married and put on weight. Something happens to them and they put on weight, and then everything gets unmasked and amplified. So that's the lean PCOS. So very good point brought out by Anjali, that just because you are thin or lean, it doesn't mean you don't have PCOS.
Right. And I know you kind of talked about it a bit, but is someone with PCOS also at greater risk of diabetes?
A very great risk for diabetes. So anything from 4 to 7 times higher risk for type 2 diabetes, lifetime risk of diabetes. And it happens at a very young age. So, and plus gestational diabetes is increased in women with PCOS. So one of the things that we want to stress from the day they get diagnosed is, I tell my patients, pretend you have diabetes. Already have it. So start eating healthy, being physically active, periodically being obsessive, compulsive about checking yourself periodically, and so that you are on top of the game, taming this thing, and that's the only way to do it. So diabetes is a very big risk because of this insulin resistance, and the higher your weight, the greater the risk.
Right. Right. Dr. Sheela, as someone who is both a OBGYN as well as you said, a physician, because you also practice in a rural area, how does how do people, women, react when you tell them about the PCOS, and how do you help them accept that diagnosis?
Honestly, Aparna, sometimes I'm surprised when they seem very okay with it.
Mm.
You know, they're like, they come in there saying, oh, you know, doctor, I have PCOS. Like, it seems to be a very casual thing. It seems to be almost fashionable to have PCOS, you know. I think that's also because they don't understand the longer term risks. See, the current problem may just be the hair and this acne, or even the fertility problem, which is most usually what they are focused on, or maybe the weight, right? Need to lose the weight. But as they grow older, these problems, especially the weight, the diabetes, the heart disease, these things are of great concern. And I think that is the part that I would like to stress, that women with PCOS, like Dr. Usha said, you know, pretend you're diabetic. The long-term sequelae of PCOS are very concerning.
Right.
So, and if you are able to, to answer your question, yes, a lot of them are very casual about it. I think it's because they don't really understand, right? Some of them, because the symptoms are so bad, you know, and it may not even be the weight, it could be the mood. You know, they have severe mood swings, they have depression, they have anxiety, they have a very low tolerance to stress. You know, anything stresses them out. So those, because those symptoms are so concerning, when you tell them that all these symptoms could be because of PCOS, there is a sense of relief that there is a reason for it.
There's a reason.
You know, there is. But having said that, that doesn't mean that you should leave it all to PCOS. Say like, oh, I have the disease, and so therefore all this is okay, and I can't do anything about it, right? So there are those two ends of the spectrum. But like Dr. Usha said, I think the long-term sequelae are really what we need to be very concerned about and be cognizant of, basically.
Right, right. You know, Aparna, sorry, that what Sheela said is so true, because I keep telling that to people. If you think about diabetes as a disease, there's no point popping in your medicines and taking your insulin and still having sugar in any form, or overeating. And it's not only coming from sweet things. It can come from a fried vada. It can come from anything that you get in a bakery, processed food. So I keep telling people, I said, please understand, by taking a medicine itself, it's not going to sort you out. They think my life is so easy because I pop in 2 pills in the morning and, oh, it's hunky-dory. No, it's not. And because both of you are here, I wanted to ask you that, is it natural or was it just in my head? I have always wanted this answer. Of course, I know thyroid and polycystic ovaries make it happen. So I used to have the crawlies because of thyroid. But there was a time where I had so much of pain. Even now, I do have pain. So inflammation also, I feel, comes along with PCOS. And it is, I don't know, you feel like an apahiz, you feel crippled, because sometimes the pain can be so much. And you have people telling, oh, every day you get up with pain. Every day you're complaining about pain, but it's real. So is inflammation really a part of this syndrome?
Yeah.
Yeah, inflammation is part of obesity. Inflammation is part of insulin resistance. So there's like that baseline, but I don't mean to take away the symptoms of anyone, but pain is not a symptom of PCOS. As in, PCOS doesn't cause it. Just being overweight, you can have lots of aches and pains because overweight people can have vitamin D deficiency. Overweight people can have, and then let me add one more thing. People with PCOS can have obstructive sleep apnea, OSA, snoring, and so they don't sleep well. They have more fibromyalgia, and diabetes and pre-diabetes increases, body aches and pains. So it's probably one of those things that's giving them the pains, but not PCOS itself.
Okay.
Sheela, do you agree?
Yeah, I agree completely. Yeah, I agree. You can't say that the pain is caused by the PCOS, but a lot of these things like the obesity and all of that, they're all inflammatory conditions. So, so then, yeah, you do feel like inflamed, and you do feel strange in your body and your aches and pains, and you wake up every morning with something or the other. But it's probably the obesity, vitamin D, all these things need to be ruled out. A vitamin D deficiency is probably one of the most common causes. And in India, most of us are low on vitamin D. So we may, despite the tropical weather, so we do need to check on other things as well. Hypothyroidism, all of that need to be ruled out.
So, Aparna, I have maybe you have a question coming up on metformin, but I just wanted to also say that a lot of people just take it like a vitamin, thinking that it helps insulin resistance. They use terms like insulin resistance, which I, as an endocrinologist, still have trouble wrapping my head around that. But they use it casually. Oh, I have insulin resistance. So I take metformin. So when you take metformin, and now we have become seriously metformin minimalists. We do not use it at all unless there is evidence of diabetes or pre-diabetes. Otherwise, no, because it can harm you in many ways. It can mask your tendency to develop abnormal glucose. Second thing, it produces vitamin B12 deficiency, which causes tingliness and numbness, tingliness, memory issues. I just saw a patient 2 days ago with all of that, and we found out it's B12 deficiency from taking metformin, which her friend gave her. So it can do that. And it's a medication. So really important that women consult their doctor, get their glucose tested, and only if it is abnormal is metformin indicated.
Right. Thank you, doctor. Yeah, I think metformin, I think at one time, and I don't know if it still is, was also being taken by people because they thought it helped promote weight loss, right? So we've had people reach out and say, can I take metformin because it will help me lose weight? So I think good point, Dr. Usha. One question for you.
No, Aparna, I've got two questions that have been messaged to me. So whenever you think I can ask them, because we have these two lovely women here, I thought I could ask them.
So I'm just asking one question and then you can ask those two questions. Dr. Sheela, somebody's asking if fibroids is the same as PCOS.
Fibroids? No, they're not. They're not the same. Fibroid is a benign growth in the wall of the uterus. When you do ultrasounds, you see them a lot where completely asymptomatic, and they usually really quite small and they don't do much harm. The symptoms are also usually things like heavy bleeding. Sometimes it could be pain. So you could have a fibroid and PCOS, but they're not the same thing at all. Yeah.
Right. Okay. Anjali, go ahead with your questions.
All right. So now there are two questions that have come. One, of course, is my question, which I'll ask next. But the first one is, because of the insulin problems that people have of PCOS, is it possible to have a pancreas that becomes slightly fatty?
Pancreas becoming fatty, their liver becomes fatty because that's what we call non-alcoholic fatty liver, common in overweight patients and people with diabetes. We also see it in some patients with PCOS, a significant number of them with PCOS, and that can be diagnosed by blood tests and ultrasound. And really the treatment for that is to lose weight, which is the magic bullet for everything. So that's really what we recommend. As far as pancreas makes the insulin, and so we really have to just make sure, keep testing for diabetes. That's all.
All right. And the second question is, which is what I want to ask you, is that when you're blessed with a lot of things like PCOS and thyroid, what happens to that person when they reach menopause? What happens to your PCOS when you reach menopause?
Beautiful like you.
Thank you, but that took a lot of effort, because this morning I was like, oh my God, my hair is all out of whack and everything. So yeah, but honestly speaking, what happens to your PCOS, so to speak, when you reach menopause? Does that still happen on its own, like one other part of the chorus, or?
They're in the background. So around menopause, at menopause, you stop menstruating. So all these menstrual irregularities go away. So one problem of PCOS is gone. The second thing is all this hair growth and all that, right? So even otherwise, in normal healthy women after menopause, there's some hair growth on the face, and some hair loss and all that. So that's, that starts and continues because the estrogen level, the female hormone level comes down, and slightly there's a uptick in the male hormone, even in normal women, menopausal women. So in women with PCOS, they have, already a little bit of a higher level of, male hormone. But I just want to say that as people get older, right, overall, this body hair growth and all that comes down. It's largely a problem of, women in their between 15 and 50, sort of largely a problem there. So that's what happens. As far as the polycystic ovaries themselves, I mean, they're there in the background doing no harm. So, but postmenopausally, what really worries, and Sheela also alluded to this, is the diabetes, the high cholesterol, the low good cholesterol, the body composition. You start gaining more weight in the upper body, abdomen, rather than the hips and thighs like it was in the younger years. So that upper body fat distribution, all that starts, which are all risk factors for heart disease.
Okay, so doctor, you're talking to me about even cholesterol and HDL getting affected. So yes, I have seen friends of mine who've asked me to help them out, and I put them onto doctors because they said they never had cholesterol, and suddenly it's 204, and their good cholesterol has come down to 45, and their bad cholesterol has gone up. It happened with me too, and that's when I called up Sheela and said, "Help me, save me, I'm going to die." So yeah, so that's also something that happens.
The estrogen levels have gone down, and normally estrogens protect you from, ones that keeps your good cholesterol up and the bad one down. And they've shown this to happen within 6 months of the menopause. So this is a quick change that happens in people. So menopause is also a time for a lot of education of women about, what Sheela does, lifestyle changes.
Yeah.
Probably,
I think we should have
say that you should do that before menopause, before the onset of menopause.
No, I think you should also, when you're doing menopause, you should have one session with the women, and you should have another session with the men. They need more education on men. Or pause. Please pause yourself, men, because it's very difficult as it is. So yeah.
I say me no pause.
Yes.
All right. Coming to the end, just before we wind up, one myth each of you that that you'd like to address, or a final message. Just go around as well. Anjali.
So, well, the final message, it's not okay, the myth is that women can't deal with a lot of things. The fact is that we are Shakti. And there are times that we have 10 hands and 10 legs and 10 hands, and we keep coming back as different forms of Shakti. So we are Shakti, but we're very fragile. And PCOS, obesity, fertility, these are signs that are, there are things that are inside us, which you can't see externally. So, once in a while, you just need to do pranam and said, okay, let me let you be alone, and we'll wait for you to return with all your strength. So that's my only thing, is that just respect yourself, respect your body, and people who don't know what other people are going through, find out and ask them and respect them as well. Because it's a very dark space, having PCOS and infertility and obesity, extremely dark space. And we try every day. But the most important thing is to be obsessively, compulsively happy. You have to get up every morning and look at yourself in the mirror and say, today is going to be a good day. Because that's what I do every day.
Thank you. Thank you, Anjali. Dr. Sheela?
I think the myth would be that PCOS can only be managed with medication and the help of pills. It's a myth, because really the primary treatment and management for PCOS is lifestyle. Right. So that would be the myth. And I think the message I'd like to leave people with is that contrary to what women or any patient thinks, oh, she wants me to do all the work. She's telling me to eat healthy. She's telling me to exercise. I have to do all the work. She's not giving me any pills. It's actually very empowering to be able to take your health into your own hands rather than sit there and wait for a handout, right? So I would like women to look at it like that. Look at it as more, of course, it's a much longer process. It's much more difficult and you do need a lot of help and support. But I think it is much more empowering. And if you really walk the course, you'll find out and you'll realize that I can do it. And like Anjali said, we do have the power and the resilience. We are highly resilient people. So the stronger sex, I would say. So that's what I would like women to know, that they need to look for empowerment rather than just being treated for PCOS.
Right. Thank you. Dr. Usha?
Yeah, so the myth is that PCOS is a reproductive problem, that it's all about menstruation and pregnancy, but it's so much more than that. It's actually a reproductive metabolic problem. In fact, they want to change the name to metabolic reproductive syndrome. So that's the myth, that it's not just about reproduction. And the message is also that I would encourage women with PCOS to think beyond acne and hair and irregular periods, and think about diabetes and long-term trajectory of good health, prevention of diabetes, heart disease, and cancers and all that. So all they have to do is get on healthy eating, physical activity, yoga, meditation, a positive mindset, as Anjali said. And then I think they can overcome this.
Right.
And
Thank you.
Aparna, also between what both of them said, what Sheela said, and I really want to say this because people should know, doctors don't want you in their lives forever. They want to give you what you can do so that you can start living. They can take the next patient in. Really, medicines don't do anything. People ask me, hey, did you have a surgery? Did you remove your fat? Did you cut your stomach? What are the medications you're taking? Honestly, 62 kilos took me 14 and a half years. I could have probably done it in 1.5 years, and maybe now I'd be dead. But because I did it slow, there's no shortcuts to good health, sweeties.
Correct.
You have to cook that food and eat it and walk and exercise.
Thanks.
Really.
Thanks. So yeah, just to wind up, I think when we spoke with lots of people with PCOS, the common refrain that comes up is people address it in kind of starts and stops, right? So they will go to one doctor. The doctor might give them a few pills for a few years. They'll do it, then they'll go off it, then they'll try something else, and then they'll go off it, try something else. It doesn't work that way, as you would have understood by now, that it is a metabolic issue. It is a lifestyle issue. So, when you're diagnosed, first of all, get a confirmed diagnosis with a physician. Do not diagnose yourself. Take the difficult route, stay the course till it becomes part of your lifestyle, right? Till it becomes simple. And that, as Dr. Sheela said, that is empowering. It's difficult. When you're young, you've got so many other things which are a priority. It doesn't seem like the thing that you want to focus on, but if you do it, then the benefits are manifold. So I think that's the message we've got from talking to our panelists today, and we hope you'll take that message. And thank you for listening, and thank you, Dr. Usha, Dr. Sheela, and Anjali for sharing and getting all those concepts across, addressing so many myths and addressing the topic. Thank you.
Thank you so much. Thank you, Aparna.